Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
It's time for episode 4. This is the Civilian Medical Podcast. My name's Sean Heron, and my co-host is none other than Skinny Medic, the cat tourniquet fanboy. What's up?
Yeah, I think that's my new nickname this week. It seems to be on all the podcasts and all the message boards that I'm the cat tourniquet fanboy.
Perfect. That's not a bad thing to be known as, I don't think.
No, it's not bad.
It's not bad at all. So what are we going to cover on this show today?
So this week we're going to cover the second phase of care, which we're kind of going to move into a transition out of our last week's episode, and then we're going to talk about airway, which is the second step of the March algorithm.
All right, perfect. So just as a refresher, we talked last week about the first phase of care, which was direct threat or care under fire. And we also talked about massive hemorrhage. So if you haven't heard that, go back to episode 3, listen to that. In fact, if you haven't listened to all of them, go back to episode 1 and start there, because we're kind of going in a path for probably the first 10 to 20 episodes, just kind of talking about everything that we would teach in a civilian medical class, which we do. So second phase of care, indirect threat or tactical field care, basically the same thing, whether you're in TECC or TCCC. But what are they?
So this indirect threat tactical field care is going to be where there's no longer a bad guy like shooting at us. There's no direct threat up on us. You know, we're probably still doing medicine in a bad situation, but there's no active threat. Like there's no fire coming at us. There's no danger presenting us immediately. So we're still, got our heightened sense of awareness up, but we're not truly like in danger at this point.
Yeah. So like a reduced level of hazard is the way I like to explain it. Doesn't mean that new hazards or the existing hazard can't come back. It's just a reduced level, so we can kind of focus on more in-depth interventions. Because don't forget, as we talked about last week, under direct threat, we really gain the advantage over the threat and then consider massive bleeding control as can be handled by a tourniquet. In this one, we're going to keep an eye out. We're going to do all those things, but we're really going to kind of move through the rest of the March algorithm until that next level of care gets there.
Right. And understand too that at any point in time, we can go back to direct threat. You can transition right back into, oh gosh, we're in a bad situation again. Whether, this be a car wreck happens beside us because they're rubbernecking, or there's another bad guy happening, or there's an explosion, or whatever the scenario is, you can transition in between phases immediately. And hopefully that doesn't happen, but that's when we're keeping that high sense of awareness around us in case we do need to transition back into direct threat scenario.
Yeah, 100%. Under direct threat, we consider hemorrhage control. If we haven't done it, the first thing we do under indirect threat is make sure that we manage that bleeding, because that is the first and most important thing that we're going to take care of. And then I think this is a really good time, and you put it in the show notes. It's exactly what I think about as well. But what about altered mental status at this point? We really have to take into account the danger, the primary threat, but also secondary threat could be a casualty with altered mental status. What is it, and what do we do?
So yes, like this is one of the things that I look at patients who are asking repetitive questions. They don't know where they're at. The possibility they've some sort of head injury. I always check them for weapons and I disarm them. I'll give your toys back to you once we get done and we make sure you're squared away. But until that point, I'm going to disarm you. I'm a small guy and I don't want to start pulling and tugging on somebody who's a jiu-jitsu master and wants to fight. So I'm at least make it fair. I don't want, this is pocket knives. This is knives on their belt. This is ankle guns. This, of course, they're primary weapons as well. So any patient that I'm dealing with altered mental status, I'm going to do a quick sweep of their waistline and just kind of secure their weapons until we figure out what's going on. This could be you're at church and you're dealing with an old man who's a diabetic. I don't, if he's altered as well, I want to make sure I take his weapon from him, because I don't want this old man who was, done tons of tours in the military, and all of a sudden he thinks he's back in the war zone and wants to start fighting again. So always, just for your safety, just clear them, make sure they're good to go.
And just to be clear, what are some signs and symptoms of altered mental status?
So I generally ask them, hey, where are you at? Do you know what day of the week it is? Do you know who the president is? Because that's always gets a good reaction to, like, it's there, like, that son of a bitch, so whatever. So, or they love the guy. That's been going on for like 12 years now. So, it gets kind of figure out that, they'll ask repetitive questioning. The unequal pupils is a late sign, but we can still kind of take a look at that during our exam. But, of course, if they start vomiting, that's a sign of a head injury. And then, if they have a head laceration, or we see kind of visual trauma to their head, that can kind of clue us in.
Yeah. Fluid leaking from the ears, stuff like that. But it's not just TBIs and other stuff like that. It can also be a sign of shock, medications, alcohol, drugs, so many different things that can lead to that altered mental status.
Right. We could do a whole 1-hour podcast just on altered mental status, like talking about what medical conditions cause that, what, like you said, traumatic injuries happen. So especially on patients who are on blood thinners, things like that, they're more prone to have those head injuries, things like that. So, but that's later on. But just kind of, if someone's not quite acting like their elevator's going to the top, then just kind of take a quick look at them.
Definitely. So taking someone's, firearm, knife, whatever, that could lead to a pretty interesting confrontation, I think, especially if they are kind of having that altered mental status. And, I know we talked about it a little bit before, but how do you approach that? You kind of say, I'm going to take your toys, I'll give them back. But, how does that go?
Yeah, like, I try to make it lighthearted and, like, make a joke out of it. If I can start that route, to say, "Hey, look, man, let me have your toys. When we get you all squared away, you can have all your toys back." And then, I'll make fun of them if they're carrying a high point, stuff like that. So, but then, once we disarm them, then I will try my best. Either I secure it, or if law enforcement's there, then I let the law enforcement officer secure it. That way we're all squared away with it. And, that way I don't have to worry about what I did with it. Did I lose it? Heaven forbid, something like that. So, if I can take all of his weapons or her weapons and then give them to a law enforcement officer, that's what I would do.
Yeah, that makes a lot of sense. All right. So under indirect threat, there's a reduced level of hazard. We're watching out for, possible re-engagement of the original, or then secondary, tertiary, all kinds of threats. We're watching out for altered mental status. One thing that I think people make a mistake of is we always have to have this evacuation plan that's kind of going. And that's the third phase that we'll talk about in the next episode. But I think some people say you're going to drive the casualty to the hospital or something like that. They will start to just run through the entire March protocol and do even non-life-saving interventions, and kind of hold off that evacuation plan. And I think the key is we're not going to delay that extraction or that evacuation for non-life-saving interventions. I'm going to do the things that are going to kill them to the best of my ability, and then we're going to get the heck out of there. So it's not run through the entire March algorithm. It's run through as much as you can until either the next level of care gets there, or you need to leave to get them to the next level of care.
Exactly. We kind of get hung up in I am obviously pro EMS, pro paramedic, but these patients don't need me. They don't need a paramedic. They don't need IV fluid, probably. They may, but that's not in this part. But what they truly need, if they are dying, is a trauma surgeon. They need surgery. They need cold steel. So if we can get them to that faster, then that's what they absolutely need. And like you were saying, if those secondary injuries, we can manage those on the way to the hospital. Like, if you want to manage your buddy's broken foot or his laceration that's oozing blood, that's not squirting on the way, absolutely, you can do that. But there's no need to get hung up on, his ankle's rotated 90 degrees. Like, I need to fix that. Like, that's a secondary injury that we can manage later on during that evac process. And, I talk about in my class, I'm like, guys, this is a little controversial, but, it may not be the best thing to wait on EMS. It may be better to throw this guy in the car and drive up to the hospital and say, here's your patient. Good luck. And I said, the cops are still going to secure this thing as a crime scene when they find out about it. But I'm like, we can cross that bridge when we get there.
Yeah, I totally agree. All right. So, I think that's pretty much it in indirect threat. It's really just reduce level of hazard, more in-depth interventions. That's if I try to break everything down to like 2 key goals. Would you agree with those?
Yeah, I agree. And like I said, we're kind of moving to that March algorithm, which is we've been discussing and we'll continue to discuss the next few episodes. So I think that's what we're looking for.
Yeah, 100% agree. All right, so we're good with indirect threat and tactical field care. Let's move into the next in the March algorithm. And again, March stands for massive bleeding, airway respiration, circulation, and heat loss and head injury. And we are on A, which is airway. So what does that mean?
So this has to do with what's around the mouth area, the throat area, basically. We're going to move into respiratory later, which will be chest area, but we can kind of focus in on the patient's face, their head, and to see what's going on. Are they snoring? Do we have blood? Do we have foreign objects we need to get out? Is there air coming in and out that we need? If there's not air coming in and out, we need to fix it.
Yeah. So massive bleeding, we take care of that first because it will kill the fastest. But blocked airway, that's pretty much next in the protocol for a reason. Like 4 minutes to completely suffocate and be beyond repair?
Correct. Something like that.
Yeah. All right. So there's several things that we can do to kind of help with airway. And again, airway and respiration are completely separate. I think people get this confused as well. Airway is making sure that the right holes are open in the right places, and respiration is actually using those holes. So now we're going to talk about what are the different methods that we can use to open an airway in our casualty.
So you can start from like very basic, like we've got, head tilt, chin lift, jaw thrust. Those are simple maneuvers all the way up to where when I get on scene, I can do a surgical crike. And, it doesn't make sense for me to jump all the way to surgical crike if I haven't done the basics first. And basics skills is absolutely what's going to save this guy's life. So we can start from very basic, just maybe we position his head to get the airway open. Now, the problem with this is if he's, unconscious or kind of nearly unconscious, and you tilt his head back or you open up his jaw thrust to open up the airway and you go do something else, well, his airway just closes right back off. So we have to put in some kind of adjunct, and we can put an OPA or MPA in there to help maintain it open. But if we have help, then we can use the bystander to help us out, because we're going to take charge and kind of be that type A personality to direct others what to do. So we can help them maintain their airway by just simple positioning, and then kind of evaluate, is there something inside there we need to clear, or is there teeth in there? Like, what's going on? And
I'm sorry, go ahead.
So, and I just want to say, like, one of the biggest misconception is about your tongue. Can you swallow your tongue? And I've heard it for my whole EMS career. It's like, oh, I put this in their mouth so they wouldn't swallow their tongue. And I'm like, guys, you can't swallow your tongue. It's attached to your jaw. It doesn't work that way.
But what it does do is go back and block that. Can you talk about like physiologically what causes our airway to close down? Like clearly crush injuries and things like that. But generally, like what are some of the things that we'll need to keep an eye out for?
Yeah. So the number one obstruction across the board is the tongue. It falls back on the back of the throat because everything gets relaxed. It falls back, it occludes the airway, and you start getting that snoring sound that we hear.
Mm-hmm.
And this isn't because your patient's sleeping, it's because their tongue is now occluding the airway. So that's where those simple maneuvers will pull the tongue back off the back of the throat and open it up for us. Now, whether that's doing the head tilt chin lift, basically where we put one hand on their forehead, one hand on their jaw, and we tilt it backwards, and that can open up their airway. We can also do a jaw thrust, which is more preferred for trauma patients. Is basically where you put the palm of your hands on their face, and you use your fingers to lift the jaw up. It's very painful, but obviously this patient probably doesn't know what's going on. So the number one occlusion of the airway is the tongue, and those two maneuvers there will move it back off the throat. Then you could get blood in there from bleeding. The tongue is very vascular. There's some things that can happen in there, bleeding from the sinus cavity, things like that can cause blood that we need to suction, clear that out. You can get some gurgling noises, stuff like that goes on with that. And then missing teeth falling back in there that, they got punched in the mouth, punched in the face, and now there's teeth missing. And then we need to clear those out before they start occluding the airway completely. You can get some like whistling noises with that because it's, the partial airway occlusion. But just doing a good exam. And if you can't if you look inside the mouth and you don't see anything, we don't want to do like a blind finger sweep, anything blind, because you can actually end up pushing it down there further. But if you open up the mouth and you can visualize, see something down in there, then we need to remove it.
Now, let's go back just a tiny bit so we can get the audio clues, like you mentioned, the snoring, the whistling. Those are some audio clues. What's another good way to kind of gauge if they have an open airway?
So I usually tell my students that if the patient can swallow or they can cough, then they have a patent airway. So, if you can tell them, hey, can you cough for me? Then if your patient's able to cough, they have a patent airway. If they're able to swallow, then they have a patent airway. So if your patient's kind of semi-conscious or unconscious and they're not able to perform, just tell me to cough, then we probably need to look at their airway and see if we need to do an adjunct or open the airway for them.
Yeah. And don't forget, if they can talk, cry, laugh, scream, that's usually a good indication of an open airway. And it just goes back to that communication. We're talking to them, asking them who their president is, and those things help us assess all these different things. So, head tilt, or actually, before we even go to that, let's real quick talk about possible spinal injuries. We have to kind of understand. We talked about previously the mechanism of injury, but if they have a mechanism of injury and we think that they might have a spinal injury, which one of those different ways would we possibly use for someone we suspect has a spinal injury?
So for spinal cord injuries and trauma patients, we really want to do that jaw thrust maneuver because we're keeping their head still and you're just lifting the jaw up. The head tilt chin lift is more for medical patients because we're tilting the head backwards. And if our patient does have a spinal cord injury, that movement could damage the spinal cord, and we obviously don't want to do that. But I kind of say that with a caveat that if your patient doesn't have an airway, they're going to die shortly. Mm-hmm. So, if you can't get their airway to open up doing a jaw thrust, then you have to go to plan B. But plan A should be doing that jaw thrust to try to maintain their head in an inline position, whether that means someone's holding it or you take some backpacks or clothes or whatever to kind of hold their head still. But, trying to maintain that head in inline neutral position is what we're looking for.
Very cool. All right. So the head tilt chin lift, just to kind of walk them through it, you're at the side of your casualty near their head. You put one hand on their forehead, one hand under their chin, and you just tilt it back and lift their chin up and away from the floor, the ground, the table, whatever they happen to be on, and then open their mouth. And then you can also look in their mouth for obstructions, anything else like that. For the jaw thrust, you would be above the casualty. They will be laying on the ground. You'll be at the top of their head. And you do, like you said, you put your palms kind of on their face and you put a couple fingers, your index finger and your middle finger, back behind that jawbone, which will be down towards the floor from you. And then without moving their neck, that's where you just lift that jaw forward and jut that chin out. It's incredibly uncomfortable and generally better tolerated by the unconscious. But even then, you're going to probably have to do it multiple times, right?
Right. I mean, this is something that you're fighting against the jaw muscles, and we use our jaw muscles a lot. So they're super strong. So your fingers are going to get tired trying to hold that open. So that's where the adjunct comes in handy. But like you said, you're holding there. You got your palms there. Your fingers are what's pulling against the muscles of the jaw to pull it forward. You're going to get tired very quickly. Your fingers are going to start cramping up from doing that because you're pulling against a lot of muscle mass there.
Yeah. All right. So those are a couple positions. Now, we mentioned clearing out debris, things like that. That's clearly a fairly risky move. Like, what is the protocol for that for you, and how do you kind of avoid risk if at all possible?
Yeah. So if I don't have any equipment with me, I'm going to log roll them to their side, kind of maintaining that head so it doesn't flop around, but log roll them onto their side and then let gravity help you out. Whatever blood's coming out, whatever teeth are coming out, we can kind of sweep it. Maybe you do end up putting your finger in there. Just be really careful putting your finger in someone's mouth. They don't bite down on it, or maybe use something to kind of sweep the blood out and then roll them back onto their back. But if I have equipment with me, one of the things I carry with me is a suction device. It's a little portable. It's called a tactical suction device, but there's nothing tactical about it. It's a turkey baster. It's not even black. Like, I don't know why I got NAR gave it the name tactical. It's not even black. It doesn't have Velcro. It's not black. Doesn't have a molly on it.
Everything's tactical.
Yeah, I'm like, you put tactical on it so you could charge 30% more. But what I tell my students to do is they're thinking about this is to go to Walmart or wherever your superstore is and buy a turkey baster. Kind of cut the tip off so it's a little bit wider opening on the tip, and then you have a suction unit right there. You squeeze it, you can suck blood out, you can suck teeth out, whatever you need to suction out, and then clear it. But you do have to be careful when you do that because some people have a gag reflex. Most people have a gag reflex and it can be very sensitive. So if you touch the back of their throat, the little dangly thing hanging back there, you touch that and they're going to puke on you. So you went from having a little bit of blood, wasn't a big deal, to now you stick this thing down in their mouth and now they're vomiting on you. And then, like for me, I'm a sympathetic puker, so I'm going to start throwing up. But so you have to be careful. So if you are going to suction, even if you could use like the little baby suctioners, like your mom had, like the little blue thing, little bulb, you could use that as well. But just only suction or what you can do, what you can see. If you can't see it, don't suction it, and don't go past the tongue because you will make them throw up.
Definitely. All right. So we've talked about a couple positions there. Let's talk about the next one, the adjuncts, as you put it. What is an adjunct, and what are the options we have?
So we have two adjuncts. We have an OPA and an MPA, and that's the simple terms for them. But an MPA is going to be a soft nose hose, basically, that goes into the nose, and it lifts the tongue off the back of the throat. Now, the really good thing about this one is the fact that it doesn't hit the gag reflex. We've had kids in class go, I'll volunteer for that. So they will awake talking, we lube it up really good, and we stick it in. It's kind of uncomfortable, but you can be fully conscious and you can have that in your airway and you're just fine. The OPA is going to be a hard plastic J-frame shape, and it goes into the mouth and sits on the back of the throat, and that will activate the gag reflex if your patient's kind of semi-conscious, things like that. So I like the MPA a lot because a few reasons. One, because a number 28 MPA will pretty much fit everybody, and the average person, it's going to fit. They make different sizes, but generally a 28 is going to fit most people. An OPA, there's sizes, there's probably 10 or 12 different sizes there you can range from, and the average adult's either going to take a number 4, number 5, and even some small adults take a number 3. So there's just wide range of sizes, and that if you don't get the right size, it's either going to stick out their mouth and not be effective, or you put one that's too small, it's going to fall in their mouth, and now you do have an airway obstruction. So I like MPAs a lot for medical patients. Someone who's maybe took a little too much heroin, or they've started messing around with fentanyl, stuff like that, where you're going to give them some medicine to reverse it. Then I put an MPA in their nose, and they walk around, or when they wake up, I'm like, hey, let me pull this out of your nose real quick. So it's better than that, so they don't vomit.
Definitely. So MPAs come in a bunch of different sizes. They're kind of a soft green rubber. I'm sure you guys have seen them. They look a little bit like a trumpet, and so they come in different circumferences or diameters, whichever way is the correct measurement. I'm not sure, but the one that most people carry is a 28 French, right?
Yeah. Number 28 would, like I said, would generally fit most adults.
Now, one of the things that you want to do is kind of measure it before you go in, and it's like a real quick 1 second thing where you kind of just hold it up to them. And earlobe to nostril is kind of the measurement. If it's longer than that, then you're generally not going to go down that far. So however much longer that is about how far you go down. And what I mean by that is once you start to put it in, if it goes an inch past their nostril, then you're going to only put it down with about an inch hanging out of their nose. And the reason is so you don't hit that gag reflex. And you can pretty quickly tell, especially in a conscious person, when that gag reflex gets hit. And if you hit it, just back out a tiny bit and tape it up.
Yep. And then we typically try to go inside the right side of the nose. That's typically our anatomy, the right side. Maybe we pick our nose too much, I guess. But that right nair is larger, so we want to stick it in there. And if you look at the end of the MPA, it has a little bevel, like it kind of slices off. So you want to put that opening towards the middle of the nose, and it's curved. And so I tell my students to give your patient a pig nose. Take the end of their nose, lift it back, give them a little pig nose there, you can see straight down into the sinuses. So when you insert the MPA, you're pushing straight down to the floor, and it'll curve right through the sinuses.
Yep. So yeah, it's always bevel towards septum, and septum is the little divider between your nostrils. And one of the important things is just to go straight back towards the spine. We don't go up, we don't go down, just pig nose them, or just lift up the nostril with the MPA over that little bit of cartilage to clear that area, and then you're going straight back. Um, you mentioned lubrication earlier. It's probably just a good thing to restate that. Use lubrication. It makes it a little bit more comfortable. It's still going to be unpleasant, but lubrication is good. Now, generally, NPAs come with their own tiny little packet of lubrication, or you can carry a bigger tube if you want. But even in a pinch, you could use the person's blood, saliva, whatever it happens to be, as long as you're being safe with the biological stuff. But lubrication, use the stuff that it comes with, but don't put a dry one in someone's nose. It's going to be pretty uncomfortable and probably not even incredibly possible to put it in easily.
Right, and then you may see some light bleeding around the MPA, the nose area, because you're going through the sinuses, and the sinuses are very vascular. So, especially if you didn't lubricate it properly, you may get some bleeding. Not a huge deal. It's not going to occlude there, anything like that. But just some people will freak out the first time they put one in. They see a little bit of blood around the nose, but it's just where you've completely rammed this rubber tubing through their sinuses.
Yep. And they're generally pretty easy to put in. You might have to twist it a little bit, go back in and out just a little bit to find the right path. But then they go in. But one important thing is we're not trying to start a massive nosebleed or anything. So if it's just not going, and you just can't get it in there, then try the other nostril. If that doesn't work as well, you're gonna have to move on to something else. But so far, I actually haven't had anybody that wasn't able to take an MPA.
Yeah, I can't remember anybody that I couldn't get an MPA. And sometimes, like, if they have like a severe deviated septum, like in their sinuses like that, you can run into an issue. They've had no surgeries, but not that I can like recall that I've had an issue putting in an
Yeah,
airway for them.
yeah, me either. Now I know that this one is one that you do differently than some people. TCCC protocols talk about. I totally lost my train of thought. Let me mark that down. I totally forgot what I was going to talk about.
That's funny.
Uh,
Are you going to talk about like head injuries? Is that what
yeah,
you're talking
head
about?
trauma, 2717.
The basilar skull fractures?
Yes,
And I cannot say I can't say those words, so I will not say orphan, or I can't even say them for you.
no problem.
Yeah, I will not say them, even if I'm like talking to doctors and paramedics, because I will totally skip over that word. I will not say it.
Okay, cool. I'll start that over now that I remember what I'm going to talk about. All right, so there's actually something that you definitely. So TCCC protocols talk about facial trauma and things like that, and when you see certain kinds of injuries that maybe the MPA is not the proper tool. What are your thoughts on that whole thing and facial trauma and injury to the upper palate and all that?
Yeah, so my opinion on it, and it's because my opinion, everybody's got one, but I feel like that if you can do a good exam of the patient, you can see that the hard palate's not fracturing like that, they will absolutely take an MPA. And if you insert it correctly, then like we were talking about, you go straight down, you don't go up towards the brain. The MPA will go into the sinuses and clear the airway like it's supposed to. One of the big myths or misconceptions is that you can't put an MPA in someone who's got facial trauma because they think that the MPA is going to go back into the brain. And really, this came from basically a study that came out, and it was that it happened twice. And one of them was NG tube, which NG tube goes down into the stomach. It's a lot smaller diameter, a lot more flexible tubing, and it did. Like they inserted it, and it went into the back part of the brain. That's never good. So I think it's not an absolute contraindication, but it is a consideration to think about. But we go back to your patient has major facial trauma. They're snoring. There's blood in the airway. If you don't do something, this patient's going to die. So just be cautious with it and do a good exam. Open their mouth. If their upper part of their teeth, the hard palate up there, where opposite side of the tongue, the mouth, is broken or fractured, then you've got problems. And obviously they have problems. And then we talked about like the basilar skull fractures, like you get fluid leaking out of the ears, like a clear fluid can come out of the ears. battle signs behind the ears, raccoon eyes. Like there's a lot of damage that goes there. So there again, you have to be cautious with it. But if you perform it correctly, then it shouldn't be a problem.
Yep. Very, very good stuff. All right. We talked about the suction devices, a little bit about the log roll, and then recovery position. What is it? What's it used for?
So I like using the recovery position for a couple reasons. One is it clears the airway if I don't have the right tools with me by chance, but it does that as well for me. Is if I get through messing with this patient and I have multiple patients or I need to do something, then I can roll them into a recovery position on their side and I can lead them. That way, if they vomit or there's blood coming out of their airway, it goes onto the ground instead of right back in their throat. And if you have someone who's laying on their back and you've walked away to go get help or to open a door or do something like that and they vomit, the vomit's going to come up and go right back down and sit, and they're going to start gagging on it, and they're going to dive because they threw up on themselves. So if you can roll them onto their side, then they throw up, it just goes onto the floor, and it clears the airway for them. So if you'll take their arm and kind of make them do a chokehold on their arm, on their throat, and roll them over, you can kind of prop their leg, their knee up to give them a kickstand, and roll them over on their side, especially when you get finished with this march algorithm before you start evacuating them out, then that's a position to leave someone in to help them out.
Yep. And the way that we explain it is just you're kneeling at their side, arm closest to you at a 90 degree angle. The arm from the other side of their body comes over their body, and it put the back of their hand on the cheek nearest to you. Lift up the knee that's furthest away from you, grab the elbow and the knee, pull them over, lock the foot behind the knee to make sure that they don't roll over onto their face and choke in a puddle of blood or vomit or anything else like that. And this is pretty much a position that a lot of people sleep in. So clearly it's a good position. It's a natural position, and it's pretty easy to put people in that position.
Yeah.
Go ahead.
And that's one of the things that we talk about in EMS, when we go back to that first responder training. If I'm working with another EMT or another paramedic and I look over and we've got 15 patients now we're dealing with, and it's just us, and I see 4 people in the recovery position, I know my partner has already assessed them and treated them. I need to start moving towards people who are not in the recovery position, and they can do the same thing. If they look over to the room and they see where I'm working and I've gotten several people turned into the recovery position, they know they've already been treated for those life-threatening injuries, and we can keep moving. So it does help if you're in a situation where you have a lot of patients and you can start directing people to move in a recovery position. It helps you know who's been treating and who hasn't been treated, even in the civilian realm, while you've got, you're at the mall or you're at the subway and there was a terrorist attack or something like that you have multiple patients, and you can kind of help start who's been treated and who hasn't been treated.
Say someone has an injury on their right side. Do you roll them onto the right side or do you roll them onto the left side? Which way does the injury face when you put someone in a recovery position?
So for me, if like a chest injury, something like that, I'm going to roll them to their effective side because I feel like it acts as a drain. If they've got someone like a penetrating trauma and we roll them to the effective side, then we've hopefully put a vented chest seal or we have put a chest seal on, but we'll let it drain. If you roll them on a chest injury to the ineffective side, that means you put the wound to the top. If it's bleeding in the abdominal or chest cavity, it has to fill up the entire chest cavity before it starts draining. So I teach to roll them on their effective side.
So for a chest injury, roll them onto the uninjured side. And for like a gunshot wound to the arm or something like that, I usually just put it up just so it's easy for me to work on if I need to.
Correct. Yeah. Like if they've got an injured pelvis, then especially if they're conscious, I don't want to roll them onto their effective side if they're conscious, because that's going to be painful. Like you said, if they've got a gunshot wound to the right leg and you roll them onto that right side, then it's a little difficult to deal with. So, but for chest injuries, I do roll them that way. It's as a drain system.
Yeah, makes a lot of sense. So head tilt, chin lift, jaw thrust, MPA, recovery position, log roll, suction devices, all that generally pretty safe and really effective for civilian medical people to do. It's something that there's not a whole lot of risk for, but a lot of reward. What happens if none of those things work and it's just still closed? What do we do as civilians, and what are other options for maybe more advanced people?
So yeah, I mean, unfortunately, that's about the realm that the average civilian is going to be able to do legally without getting into some legal trouble. One of the things that advanced providers can do is called a surgical airway. It means I take my scalpel out and right across your voice box. I cut a straight line down that's going to expose the larynx, which is your voice box, and then there's a little piece of cartilage in there that's is very thin that I can cut with a scalpel, and I can insert a breathing tube in there for you, so I can completely bypass the mouth, the nose. I can bypass all that, put a breathing tube in there, and you can breathe now. But that's a huge risk. I've never done it in the field. I've trained on cadavers. I've trained on pigs. Trained on mannequins, but I've never done it in the field. I know lots of FS dudes, that special forces dudes, that have done it and said, once you get past the first cut, it's all downhill from there, which I agree. But you have carotid arteries running on either side of your neck. So if you miss your landmark, you can cause a lot of bleeding, and this could be a big deal. So for the average civilian, this is not something you're going to do. You're not going to be at your favorite steakhouse, and pull out your scalpel and start cutting on someone's throat. If you do, then you understand that there's a huge risk of liability, and this is not going to cover you on the Good Samaritan law, things like that. So, I demonstrate it in my class, but I'm very clear in my class that this is not covered in the Good Samaritan law, that this could open you up to go to jail. But I have students who say, you know what, but if my wife was injured or my brother was injured, I would absolutely do this. And I'm like, okay, then that's on you. But just fully understand the legal consequences of doing this.
Yeah, 100%. One of the example videos in a TCCC class shows an Afghan commando that's embedded with a group of U.S. military, and steps on an IED and gets blown up, and it throws a bunch of people kind of around. And when the medic starts working on him, the medic is clearly confused, but they keep pushing the guy down. The guy keeps trying to sit up, and they keep pushing him down. Like, stop it! You're gonna hurt yourself. Just lay there and be still. And the guy is just constantly trying to sit up, trying to sit up. Well, he's trying to sit up because, as human beings, like, our instinct is to adopt a position that's going to allow us to breathe. And if we can't breathe, our body and our instinct and everything inside of us is going to try to get us to move to a position to breathe. So one of the things is, if someone is constantly trying to sit up and you don't suspect they have a spinal injury, like, let them sit up. We're not trying to restrain people or do anything else. They're probably just trying to either adopt a position where they can actually open their airway and breathe, or they're just, kind of panicked. But I always err on the side of, letting people be free, because I am a civilian medic. I have no duty to treat anyone, and I'm just trying to help them out. I'm not trying to trap them, hold them, kidnap them, or anything else. So if they're usually trying to sit up, generally it could be because they can't breathe, and it's generally a good idea to let them do what they need to adopt that open airway.
Exactly. I think about one of the pictures that's like, it's probably one of the famous pictures that goes around like the EMS world, is there's a guy he was trying to commit suicide, and he shoots himself in the face with a shotgun.
Yep.
And it looks awful. I mean, he's got just chunks of meat, like his nose is gone, his face is gone, his cheeks are gone, but he's awake and looking at you when you take the picture. So it's always that question of, like, students, like, oh, how do you manage his airway? You're leaning forward, like you were saying. Like, there's no need for me to stick anything in his nose. There's no need for me to stick anything in his mouth. There's no need for me to cut his throat. He's awake. He can probably talk. Lean him forward and let the blood drain out, and let everything, like you were saying, just let him manage his own airway.
Mm-hmm. Yeah, sometimes not getting involved and just letting them adopt a position that's natural is the way that we manage that airway.
Exactly.
When you come into a situation, we'll say just multiple casualties, you suspect that someone has a obstructed airway of some sort. You don't see any obstructions. They're kind of just laying on their back. What's your go-to? Do you use the positions, or do you just go to MPA because it's guaranteed to work?
I do start with the positions. I really do.
Okay.
It's just habit. I start with the very basics, doing the jaw thrust, stuff like that, and then I will move forward. Typically, our airways in EMS, or even in my trauma bag, are buried. They're not up front. I keep my massive bleeding things up front, so the airway stuff is in the next pocket or they're in another area. So if I can open the airway and then have a bystander or have my partner say, hey, I need you to unzip that pocket there, get the MPA out, lube it up. While you're doing all that, I've got the airway open, I've got it secured. So I really do start from the very basics and work my way up.
Yep, makes a lot of sense. And that's the reason we presented them in this order. It's the head tilt chin lift for non-spinal, for possible spinal or trauma patients. It's going to be that jaw thrust maneuver, then MPA. If you're going to walk away from them or just kind of done for the moment, that recovery position. And I think that just about covers everything that we have for airway.
I think so.
All right, cool. Well, in that case, let's go ahead and just remind everyone so far the 2 phases of care that we talked about. If you go by TECC, it's direct threat and indirect threat. If you go by TCCC, it is care under fire and tactical field care, those 2 situations. The 2 primary fundamentals under direct threat or care under fire are gain the advantage over the threat and consider bleeding control. Under indirect threat are reduce level of hazard, watch for additional hazards, and move through the rest of the in-depth interventions for the March protocol.
Yeah, and in our March protocol is going to be massive bleeding, airway, respiratory, circulation, head injuries, and heat loss.
Perfect. I love it. So we talked a little bit last week about some of the stuff that was going down with the rat tourniquets. There's been some developments there, and I figured we would just talk about it. What's changed since last week?
Yeah, like this really has hit the fan, it seems like. So I just want to let everybody know about it. There's been plenty of articles posted about it, videos have been done about it. So if you're not in the middle of the medical field, you may not have a clue what's going on. So just to kind of give everybody an idea about what's happening with the rat's tourniquet. And that's where I've gotten my nickname here this last week or so, the cat tourniquet fanboy. So
yeah, exactly. So yeah, there was the website published kind of anonymously that shows a lot of things about studies with data that indicates that maybe cat tourniquets aren't as effective as they should be. But basically, it's a disinformation campaign is the way that I read it. And it has blown up. You're absolutely right.
Exactly. I read an article, and it's on what a healthcare site where they publish articles and all that, and they were talking about the cat tourniquet. They were talking about Stop the Bleed campaign, and said that when students are 1 month out of Stop the Bleed campaign, their skills have already come down a little bit. It's still not bad. I think if I remember correctly, it was like 6 out of 10 students couldn't get 6 out of 10 could get the cat to work after 1 month of class. But that's the same stuff we see with a CPR class. Someone takes a 4-hour CPR class, 1 month out, their skills have kind of went down a little bit. A year out, their skills have went down even more. So that's why we recertify CPR every 2 years. So it goes back to training. If you're going to carry a tourniquet, you have to train with it. It's not one of those things where you took a trauma class last year and you are good for the rest of your life. You've got to keep your skills up. You got to train with it. You have a trainer that's a dedicated trainer, and you have to train with it.
Yeah. So I guess just to kind of restate what we did last week, we have both historically taught rats tourniquets. We have both carry, and I still carry a rat's tourniquet because I understand what its weaknesses are, and I would only choose to use it in places that I'm sure that it has a good chance of success. I understand those things, and I make those decisions based on that.
Right. I've done videos on the cat or the rat in the past, and I've caught some flack from it because I've said the rats will work. Yes, a rat tourniquet will work as a tourniquet. Does it run the risk of nerve damage? Yes. Does it run some other risks? Yes. Is it, the best tourniquet on the market? No. And what I've said in the past is I would rather see someone, because those things are easy to carry as far as your EDC. There's guys looping it through their belt, dropping it in their pants leg, and there's a number of ways you can carry the rats. So it does make it easy to carry for an EDC, but it's not the best tourniquet on the market. It's not the perfect tourniquet on the market. There is no perfect tourniquet on the market. So I would rather see someone tell me they're going to carry a rat and use it than say, you know what, I'm just going to use my belt. I'm going to use 550 cord. It's better than that. But there are better tourniquets on the market that I feel like are on the market.
Yeah, and I carry one as a backup to my backup. I probably will continue to do so. Um, Generally, our issues were just that there's some interesting behavior going on. Now, Jeff Kirkman, the inventor of rats, was on with James Yeager last night, and just it was a live video kind of interview style thing, and he addressed some of the things, but it did not go the way that I hoped it would go.
No, and it didn't mean like he did address the concerns that I had because one of the things that I was concerned about and it kind of always been on the fence about rats was when they first came out, they had that TCCC approved stamp on their packaging, and that did always kind of bug me that he did that. But in the video, he explained why, his side of that and the fact that he did realize that that was a little shady, so he discontinued it, didn't do it anymore. So like I give him props for that. But there's just a lot of shady stuff that was going on that I wish would have been asked a little differently. The fact that he went after Andrew Fisher, and like made a website, stfisher.com, I believe it is, this evidence-based medicine.com. And he did bring up the fact that the cattourniquet.com and NorthAmericanRescue.com, which I can't believe North American didn't have those registered. That kind of, I'm like, what are you guys doing?
Yeah, it's a little silly.
Yeah, I'm like, come on. Like I kind of point that one back towards NAR. I'm like, come on, dudes. Like this is your company. This is your baby. You should have the domains for that. So
Yeah, I 100% agree. So this evidence-based medicine, this is the thing that's really popped. It's a website that was published, not surreptitiously, just published. All the data is actually hidden, and people had to do reverse DNS searches to find that it was actually registered to him and his company based on what other websites were on this server, and he basically did admit that this is his website. A couple things that he said that I thought were interesting. People have accused him of nitpicking segments of data, and he's like, no, the whole report is on there. But the way this website is actually structured is it has an image that says click to read more, and then on the right it has a quote in bold yellow text or bold black text and a yellow box. So it is clearly meant to draw your attention of how a cat tourniquet failed in a specific situation in this study or whatever it happens to be. The only articles on here are stuff where the cat tourniquet failed or the rat tourniquet outperformed the cat tourniquet in every one of these studies. And I haven't read all the studies. Clearly, they're picking and choosing the data and the quotes that they're putting in here and highlighting, which I think it's disingenuous at best. But he said when he was on with James Yeager that he wanted to have a place that had these studies and that he's not purposely just picking tidbits of data, but he clearly is. He also said that he did this to start these conversations because he thinks it's important that we have these conversations because that's what America was built on was good dialogue and debates and good and healthy dialogue and debates. And I say you are clearly picking specific bits of data that show the cat failing or the rat succeeding. That may not be what the study is about, but you're using the headline trick where you're doing the clickbait thing where all people really are going to read is that big yellow bold box, and then they're going to make a decision based on that. They're not going to read an entire medical study. But then he says that he wants to encourage debate, and I say also false because there is no place on this website for debate. He says that he wanted to have these discussions, but he does it under anonymity. And then he goes on to talk about the people that are coming after him in anonymity. And like, I don't think he's a bad dude. I think that what he did is shady. And had he just said, yeah, this was wrong, maybe I'm gonna redo it and I'm gonna do it in a better way. Like I can respect that, but there was no responsibility taken. And the stuff that he said he was trying to do, this website is clearly made to do the opposite of those things.
yeah, I agree. I mean, if Jeff is at NRA, man, I would love to drink a beer with him and talk to him. It's I feel like if you're on Instagram, like I saw, like this wrecking crew, this evidence-based medicine crew, were definitely going after him, no doubt about it. They went after him. They went after him, and they also went after Stat Medical. This is the zip tie tourniquet, full on. And even a buddy of mine, Chris, who does the Medic Up podcast, we were like, dude, this is going to get out of hand. And he was, we were talking back and forth, and I was like, I agree, this is going to get bad. This was months ago when all this first started. Chris was like, dude, this is going to get bad. Mark my word. and now it has, like, it's exploded. And so I feel like for me, my company, Medical Gear Outfitters, we're a distributor for a lot of companies. We're a distributor for North American Rescue. We're a distributor for TACMed Solutions. We're a distributor for H&H. So, and we were a distributor for Rats Medical. So we would, here's the products. You guys make your decision on what you want to carry in your kit and carry it. So when all this came out, I was like, man, he is picking on the big gorilla in the room, North American Rescue. Like, they are the big gorilla. They're the top of the food chain. And so for me, North American Rescue has been fantastic to me. They are awesome to Skinny Medic, the YouTube channel. They are great for Medical Gear Outfitters, the business. I could call them right now and say, I need this by this afternoon, and I would have it. I've done it. I needed a jet tourniquet, which is a junctional tourniquet that you can, it's got screw down. It's like little pizza slices that go down. It's for, I can't get a tourniquet up high enough. I was doing some training at a local EMS service, and I was like, man, my jet tourniquet is gone. I can't find it. I made a phone call and I had it by lunchtime. So those guys are awesome. I've ticked them off before when I've talked about, the cat, not doing this, not doing that. And, but they're all my friends. And so I felt like I was being pushed to choose a side. And when I felt like that, as a social media influencer, like you are, Sean, that we have to pick a side, and that's, I decided I was going to pick rats. Or not rats, sorry, cats. I can't talk. I was going to pick the cat tourniquet to be my side. And so, people were talking about it last night. They're like, man, NRA should be fun. I'm like, yeah, like, I'm going to have a cat tourniquet in my pocket for the NRA. And if Jeff's there, like, I would love to talk to him, drink a beer, and let's talk, let's do dinner. But I think it has blown up really bad.
Yeah, it really has. And like, I went in to watch the James Yeager thing because I thought it was going to be a train wreck, and it really was. Like, the interview didn't go like I thought that an interview should go. Like, the questions were softballs. There was no tough questions asked. There was constant interruption just to shower praise and adoration onto Jeff. And I kind of found that a little bit annoying. And I'll say this, and I've said this publicly 1,000 times. Like, James Yeager, I've met him 2 times in person. Literally one of the nicest people I've ever met. I've heard stories about him that are amazing. I've never trained with him, but I totally would. Like, I have no problem with the dude whatsoever. I didn't love the way this interview went because there's tough questions that needed to be answered, and those questions weren't answered. Now, there was also people asking questions in the chat that I thought were pretty dang good questions that didn't get asked at all in the podcast. And I thought that they were important. And I don't know if they were just missed or if they were skipped on purpose, but they weren't covered at all.
Yeah, I agree. Like, I know some of the guys that one person individual is on the TCCC committee, and he was asking questions, and they were getting looked over or not answered, stuff like that. And I get that Yeager was blocking some people because you don't want it to get out of hand. It's kind of a fine line. Like, you want those good questions to ask, but you don't want this to be a pissing contest either. So I get it. Like you said, I've met Yeager several times. Yeager and I, he has my phone number, I have his phone number. I actually have a good story that, I just ran a nasty call. And it was probably the first Iraq veteran shoot that I'd been to. And man, I was like deep PTSD. Like, I was having some problems with it. And some guys were sitting around and they were like, man, what's the worst call you ever ran? And I was like, here it is. Bloop, and I spilt it like right there. I was like, it's a little girl who got run over by a lawnmower. She got degloved all the way up. And I was like, and I put my hand on her pellet. Like, I was like, boom. And Yeager was like, dude, you're not right. And I was like, no, like, I just ran this call. Like, I was mad. I was still angry. And he was like, let's go away. Like, and he walked away with me, and we talked for like 30 minutes. And from that point forward, like, afterwards, I had a huge respect for Yeager.
Mm-hmm.
But I mean, there again, he's one of those dudes, you either love him or hate him. But for that moment in time, I was like, dude, this guy's, and he's met my wife and kids, and he treated them very well. So, but I do wish, like, I almost wish we could have gotten a panel together. Like, there would have been some different guys that were on video that could talk about it and ask those tough questions, and and not to make anybody look like a bad guy when it comes out of it. Like, I don't want to, like, I wouldn't want to see Jeff come out of this looking like the bad guy, but there's some questions I would like to have seen better.
Yeah, yeah, totally. I mean, the Jeff is a 28-year military veteran, deployed multiple times, was a ranger. Like, this is a dude who has literally written a blank check for his country, and I respect that. I don't respect some business things that he's done and his explanations of them. I don't buy at all. This is a disinformation campaign. That's exactly what this is. And if you are doing that and you get caught doing that, then just admit to that and be like, you know what? How can how can we do this better? Because I think this data is important, and how can we do it better? And what you'll notice on this website, there's no rats tourniquet studies that point out specifically that the rats was the inferior product in these tests, but we all know that there's a lot of them out there. And to be 100% clear, like, I have used rats in my classes. I have done testing by myself in the office at night with Doppler and rats, and 10 to 15 times doing something over and over and over again, and then cataloging my results. And I didn't do that because I published it, because I never published it. I did it for me because I was like, well, if this is something I'm going to carry, I want to make sure it works. I don't want to just take someone's word for it. And it was less effective than every other option that I tried that night. But I was like, this has a purpose. This will work in these cases. I know what those cases are. And then I chose to do it. So philosophically, you made that choice and I made that choice to no longer work with the rats, because there's just, that shadiness going on personally.
Yeah, and I don't regret the decision. Move on from it. I hope, but like you said, there's issues with a cat. Like, even Jeb brought it up. Wearing gloves. If you've got like the mechanic's gloves or work gloves on, and you're trying to mess with the cat, that can be a little tricky. The Velcro can get hung on close sometimes. There's definitely some issues, but it's training. It's over and over and over again working with it. The Soft T is a great tourniquet. Is it the best one-handed? No. Okay, if we could make that buckle, just figure out that buckle issue, they would have, top down the best tourniquet, because I like the metal windlass. I like the new track system they have on it. If I've got both hands free, Soft T, no problem. But if I'm one-handed, my offhand, the Cat Gen 7 nails it.
Right. And you can't carry 17 tourniquets with you, in your everyday carry. So you have to pick the one that you think will work the best for the most situations. And I think that's generally why most people pick a cat tourniquet, because in one-handed situation and a leg situation, that Gen 7 is pretty damn effective in just about every way. And look, are there occasions when you put a cat tourniquet on, a normal adult leg and it doesn't completely occlude blood flow? Absolutely. That's why we recommend to carry two, because sometimes they don't. And that second application is important. It's why it's in the data. It's why it's in the reports and the studies. So is there a perfect product? No. We just have to kind of figure out, what are the odds of these things happening, and make our choices based on those odds.
Yeah, I agree. I don't have any prior military experience. My medicine is all civilian based, but I've used the cat tourniquet 6 times pre-hospital, and every time it worked. On arm, leg, it worked. One of the It's been several years ago now, but I applied it to a gentleman who lost the lower part of his leg, and he said that the cat tourniquet hurt worse than the actual injury. So, I mean, they're painful, they hurt. But for me, I've used it 6 times in the field, no problems whatsoever. And even the guy who amputated his leg, the trauma center reattached it. So, like, that was a crazy moment. I was like, man, they reattached this dude's leg after I tossed it on the stretcher. The trauma center reattached it. So, I agree. There's no perfect tourniquet on the market, and if I could develop it, I would be drinking a beer on a beach somewhere right now. But there is no. I like the innovation. I like that there are multiple tourniquets coming out in the field. Like Combat Medical has was it TMT, I think, or anyway, Combat Medical has a tourniquet they're coming out with. The SAM tourniquet, I like it a lot. So there are some good tourniquets on the market, and I think there's room for more tourniquets to be there.
Yeah, I 100% agree. And, if people have rats and they carry rats every day, like, don't think that people are going to look down on you for doing so. I mean, the internet is going to, but not because of this issue, just because the internet is the internet.
Yeah, like, if you own a rats, don't burn it. Like, don't do it like I did. I did it just to get some attention, and I did. It worked. Don't burn your rats. Keep carrying it, but I would just encourage you to do training with it and be proficient with it.
Yep. And understand the weaknesses. And that goes with everything in your med kits. don't take our word for it. Especially don't take the manufacturer's word for it. You can take scientific studies and things like that, but generally get one, practice with it, figure out what works for you, and know everything about it, how to use it, and how to make it effective.
Absolutely.
All right, that I think we'll do it for this episode. I don't see anything else in the show notes. We good?
We're good.
All right, very, very cool. So again, we covered airway and indirect threat slash tactical field care. And I think we covered it all pretty well. If you have any questions, concerns, anything else, you can go to civmedical.com. And Dietrich, have a good weekend. And I can't wait to talk next week.
You too. Thank you.
Find us and subscribe at civmedical.com.